I really appreciate everyone joining us today. My name is David Notrica. I'm a pediatric surgeon at Phoenix Children's Hospital. I'd like to introduce our other panelists for today. We'll start with Dr. Jessica Naiditch.
Hi, my name is Jessica Naiditch. I'm a pediatric surgeon and I'm the trauma medical director at Dell Children's in Austin, Texas. Thanks for having me.
My pleasure. Dr. Chris Newton.
I am Chris Newton. I am a pediatric surgeon at UCSF Benioff Children's Hospital in Oakland.
Excellent. And also chair of the pediatrics committee for AAST.
Yeah.
Dr. Romeo Ignacio.
Romeo Ignacio. I'm the trauma medical director here at San Diego.
Dr. Katie Russell.
Hey guys, my name is Katie Russell, and I am the trauma medical director at Primary Children's Hospital, which is in Salt Lake City, Utah.
And Dr. Howard Pryor II.
Hey there, I'm Howard Pryor. I'm the trauma medical director at Texas Children's Hospital.
So we really appreciate everyone joining us today for this AAST session. It's sponsored by the Pediatric Surgery Committee of the AAST, and we have some really amazing cases for you. So with that, I'm going to go ahead and let us get started. And I think Dr. Howard Pryor has the first case. We'll stop, and this is called the hot seat session. So we'll periodically stop and ask our panelists for their opinion. So Howard, get us started, please.
All right, I'm going to share my screen here. I'm going to present a hepatic foreign body case that I was involved with a couple years back. No disclosures. Let's go to the next slide. There we go. This was a 13-year-old patient who came in while another one of my partners was actually covering and was supposedly playing around in his driveway and fell off to the side onto a pile of broken glass. And came in with a right flank laceration from this glass that he fell on. There was a small piece of glass protruding from like about a 2-centimeter thoracoabdominal wound. He was otherwise hemodynamically stable and intact. He arrived fully clothed. They kind of thought this was just going to be primarily a skin laceration and kind of slow rolled it a little bit and just kind of checked him over, took their time. These are the vital signs on presentation. They drew the usual rainbow of trauma labs. None of them were particularly remarkable, but he was complaining about some right-sided pain and kind of said that it hurt when he took deep breaths. So they got chest x-ray. And on the chest x-ray, which is a little bit extended, thankfully, I think you can kind of see down there in the circle, there seemed to be some opacities that were unexpected findings. All right. So he also had a little bit of right-sided pleural effusion. So there was some superficial glass, and they were able to easily remove it at the bedside. And God, sorry about that. And placed some gauze over it. Are you kidding me? And kind of paused right there to think about what to do next. So any thoughts on what anyone would want to do at this moment?
So Howard, you took the glass out before you did the x-ray or after?
There was glass that was actually sticking out of his skin, and that's what got removed before they did that x-ray.
Okay.
And was there any active hemorrhage or signs of a hematoma based on your exam?
Not really. It was just a pretty clean looking laceration, actually. I mean, it was like a slice, it looked like a knife cut.
And an abdominal exam outside of that incision was relatively benign.
Relatively benign. When you got into the very lateral right upper quadrant, it was a little bit tender, not inconsistent with just pushing on lacerated, soft tissue.
Wow. Anybody want more information? More imaging?
I think more imaging. If you didn't have that pleural effusion, I would say get a lateral just to see how deep that glass is at first. But given the pleural effusion, I think I'd go straight to CT. That makes me concerned it went intra-abdominal.
As long as the kid's stable, I agree. You need further imaging to figure out what's going on. I think it's going to be hard based upon a kid who looks relatively good at this time. So,
Yep. So
So
that's
what do you do?
that was exactly the next step. I think this is a CT scan. Oh, sorry. This is a CT scan I can get to play here. And this will just scroll through. You can see the glass up here.
oh,
That's
yeah,
What
Yeah.
is in there?
Whew. Uh,
that's making my side hurt.
the good news is it comes right up next to the right hepatic vein branch, just as it takes off on the IVC. So now what do you want to do? Rush right in there, right?
wow. Let me start with the Dr. Newton. What do you want to do with that? Can you scroll back just a little bit on the images so we see the horrific one?
Okay, let me see if I can.
Right there.
Yeah.
That's
Okay.
tip to the right
Yeah.
hepatic vein. And then kind of
Oh, wow.
Yeah. Hey, Newton, what do you want to do with that, man?
So it doesn't look like it's actively bleeding.
say that again.
Doesn't look like it's actively bleeding.
At this moment, it's not
Hepatic
active.
vein's okay.
Mhm. Yeah.
Where did the glass come from again? What was the origin of the glass? Do you remember?
Supposedly a pile of broken glass kind of sitting next to in between a fence, broken glass, driveway car, and he was just like bouncing around in there. Something had fell over on his side onto it. Was the
So
story.
super sterile, right?
Yeah, totally sterile.
Okay.
Outdoors.
The last deep glass I had was from a snake terrarium. I mean, like you couldn't
Oh my
ask for
gosh.
deep.
God.
Your IV docs love the questions about the antibiotics.
It was. You think it would just like be some hypothetical question, but it's just totally real. All right. So, Chris, what do you want to do?
Well, the grand question is, are you going to leave it in or take it out? And it sounds like he's completely stable and not bleeding, which makes you at least initially question, could you possibly leave it in? Personally, I'm worried about what that glass is going to do over time, where it is located to the vessels. And if it's close enough to the liver edge, I'm going to be tempted to go get it.
And it's also, it sticks out through the rib cage, right? So it looks like it could kind of like get moved over time.
Right.
There's let me see if I can get back there. There's actually that cracked off right there. So it breaks, and then this is a separate piece in the liver.
Oh,
Yeah.
Yeah.
But it's not far. The where it extends to the edge of the liver, at the dome of the liver, it looks like it's only a couple centimeters deep.
It's
So-
interesting. There's no hematoma. There's no extravasation. It's just the
Right.
full body. I don't see a large hematoma surrounding this, and there's no evidence of any free fluid I could see outside the capsule on these images. Was there any free fluid in the lower pelvis at all?
No. Actually, it looked like a pretty dry abdomen overall, surprisingly.
All
That
right.
is just amusing.
So I guess we have to vote. Who wants to take it out? Okay. All right. Well, there you go. You have a hall pass to the OR.
So
I
at
don't.
2 a.m. So here's what actually happened at 2 a.m. My partner just did a very gentle wound exploration and a diagnostic laparoscopy to make sure that the diaphragm was not more seriously injured. They did find a diaphragm laceration. They repaired that. They took out the superficial glass piece, and found about 450 of hemothorax, which is what the effusion was. Cleaned all that stuff out and put a drain. Which I think this is the 2 a.m. thing. My partner's thought at that moment was this was not the moment without all hands on deck to
Right.
go do a liver exploration, but felt that it was not acceptable to just leave that other piece of glass floating around potentially in the chest. So that was the thinking. But then we all got together to talk about what we were going to do as our next steps. So,
So to recap, Howard, what exactly now is left in at this point here? You took out the superficial piece, and you have what exactly left now?
just the big piece of glass in the liver itself. So in talking this out, the other thing, there was issue about getting blood availability at that moment. It was kind of a weird circumstance that they'd had an MTP and they were acquiring more blood. So that was another reason why not going after a liver item seemed like not such a great idea at this moment. There was a lot of tenterhooks and stuff.
And do you have hybrid capabilities? Obviously not at 2 a.m., but do you have hybrid capabilities at your institution?
And at that time, no. So what we did, what hybrid thing, actually, that's a good question, Romeo. What hybrid thing would you want to entertain?
Well, I think that was very wise for the surgeons here at 2 o'clock to say, hey, we're non-extremists. We don't have a full team. We don't have everyone here. Let's take a pause and rethink about what we can do in the AM hours when everyone's there. And then 2 is if you decided to take this thing out, you want to be prepared and have a contingent plan for like steps A, B, and C. It's one thing to say, hey, I'm just going to pull it out and see what happens. But if you don't have a contingent plan of what you're going to do, if you have uncontrolled hemorrhage, if you don't have a way to get some sort of like a control through endovascular methods and stuff, I mean, you're setting yourself for failure. So if you had the hybrid capabilities, I would consider that and talk to those guys and see what we can do, at least to control bleeding. Now, obviously, we don't have those capabilities here. And so our approach might be a little bit different of just, getting proximal, distal, above and below the liver, and just making sure that we're prepared for blood products and so forth. But I think it's very, very smart of the surgeons to take a pause, because some of us just want to get things done. But at 2 o'clock in the morning, it was probably the best thing to do for this kid.
Yeah, I agree. I think it was a very smart decision at that moment to say, I've got a stable situation and I'm going to wait. They left the kid intubated, by the way, so that plans could be made without waking up and coughing and all that other kind of stuff, which I also thought was very reasonable.
Dr. Naiditch? Oh, sorry, Dr. Russell, you can go first.
I mean, I was just going to say to like play the, I mean, I know it's easier in retrospect, but could you have waited and not done that operation? Like you could have just put a chest tube in the night and then been totally prepared the next day to do what you're going to do in one operation.
It's a good question. That's valid also. I think they were planning that they were going to intubate the kid because they wanted to keep motion restricted and they wanted to get a chest tube in. So I think some of the attitude was, well, if we put a chest tube in and it's bleeding, that could be because the diaphragm has a laceration and is just bleeding from that. And how will we know? Why don't we go address at least the chest part and get some of this glass out and then regroup? But I agree, God almighty. I agree that it's possible to kind of go either way on that discussion.
Jessica?
I don't think that's a hard answer one way or the other.
Yeah, I was gonna ask the same question Katie did. I agree. I would have considered waiting for that till morning, do the chest tube at night, but I completely agree. 2 a.m. Don't need to touch that liver piece of glass. Get your ducks in a row. Make sure you've got your blood available. Make sure you've got IR on backup if you need them, whether or not you have a hybrid room, and be ready to go after what could turn into a big problem.
So,
we know they're blowing you up about umbilical hernias.
Yeah, actually, it's a GJ tube placement.
urgent.
Don't you have a resident for that?
Just the resident blowing them up. It's interesting, Howard, because I look at this glass and I think about, all bleeding stops. And I think stopping that night was great, but I probably would wait 48 hours. Thinking that whatever it's injured, it's going to clot off. The bile duct's probably not going to clot off. 48 hours and then go in. Just a thought.
Interestingly,
it was Friday and you couldn't do it till Monday.
It was Saturday and it ended up being 48 hours anyway, because we came up with a battle strategy that does involve something akin to hybrid room, and we needed to organize resources for that. So let's see. I'm going to show you these films here. I think this shows you where the glass is located. The A is relative to the surface. C is relative to the posterior vessels to some extent. And it kind of gives you a little bit of a transit idea between A, B, C, and D of where this thing is located.
Yeah.
We'd got minimal chest tube drainage out of the chest tube that was placed. There was no pleural effusion. And so at the end of the road, we were kind of felt we were in a pretty good spot. Our concern was if the right hepatic vein was the branch that was injured, and it's right there next to the IVC, how would we control that bleeding for sure? And we wanted to have a couple of different scenarios in place. So we talked to I favor endovascular hemorrhage control for trauma when it's feasible. And we had a vascular surgeon who was able to put up a bridge balloon to place a bridging balloon behind the liver and left it deflated. And then we did a limited XLAP. Actually, I think this is post-op from our first case. This is just showing that our pleural effusion was addressed and all that stuff. And then we already kind of covered this next slide.
Okay.
So, so we placed a occlusive bridging balloon behind the takeoff of the hepatic veins, and then deflated it and left it in position, but not deployed. And then we made a Coker incision and placed a Pringle ligation slide on there so that we could execute a Pringle maneuver if we started having exsanguination. And got blood in the room, had adequate access, hepatic monitoring, etc. And then once we were kind of in the right position, we this is our subcostal incision, Pringle. We performed that right subcostal incision, and this here is our exposure. Let me see where we are, and I'll just see if this video will play. Yeah. And so we bovied and tapped until we could actually feel the glass. It wasn't, there was a stellate incision on the surface of the liver, so you could tell where it had gone in. And then once we could kind of feel it, we knew its transition. This is the slow removal of the piece of glass.
Oh my gosh.
Wow.
That's a great video.
Yeah.
Yeah, somebody was planning for this.
We spent some time thinking about what we were going to do.
Hey, Howard, between the two operations, did you do a repeat study? Did you repeat CT with contrast or?
No, we didn't actually. We discussed it a little bit, but we felt like it would not really add anything to our decision making because nobody really felt comfortable leaving it in there.
It's fair.
Yeah, that was at the end of the road. At the bottom line, it just came back to nobody was comfortable just walking away from this thing. So we're like, oh, we're going to go get it. And what's a CT going to tell us more than what we already have?
I think, yeah, I think that was a good decision. I think, you know, when you have glass separating a minor bile duct that's been cut, you know, we don't think much about these tiny little bile ducts because they just kind of like, you know, find the other end or they seal or whatever. But I think if you interpose glass in between, I think it's going to be hard for them to I mean, I don't think anybody's ever left it in, but I think it'd be a little bit harder for them to seal up. So
yeah, and form a bioloma of some type or something. Yeah.
So super cool case.
Yeah, poor kid. I mean, didn't come from the nicest neighborhood, but he was a really nice kid. He did fantastically post-operatively. We put a little Band-Aid on his neck. Thankfully did not have to use any of the hemostatic measures that we prepared for. Because I do think, as you said, Dave, leaving that 48-hour window may have allowed enough, you know, occlusion of blood vessels that we didn't have a big mess to deal with. Don't know. We didn't really see that much blood no matter what anyway. The bleeding in the chest might have all been from the diaphragm laceration. Hard to tell. Super
cool. All right. Well, awesome. All right. Is that the final slide?
That's the final slide. Yeah.
All right. So I think with that great case, let's move on. I think Romeo has the next one. We're not excluding our female surgeons. They actually just did all the cases last time, and none of the boys got to go. So, all right.
Do you see my slide?
I can. It's great.
Right, good. So I do like that. I like the other case though that Howard presented because it's taking a pause. And I think that's really hard for us surgeons to do, but I think it was wise for them to, re-strategize and come back forward. So we're going to present this case for those who went to Western pediatric trauma. We actually discussed this and look forward to the conversation here. So we have this child at the scene. It was called, was actually roughly about 12 years old at the time, was non-helmeted, experienced a fall from a bicycle. It was not an e-bike. He was ambulatory at the scene, trying to call his mom via his phone. But then a corpsman nearby noticed that he looked very pale and white and was just not really with it. So he called the local fire department, and en route, while he was waiting for the fire department, he noticed his breathing was erratic. They thought he was a lot sicker then. So when the firefighters came, they requested for air transport. So the pre-hospital events are the following: is that when he was there, he obviously looked like he was an extremis. He was pale. His pupils now was less reactive, and his GCS went quickly down to 3 as he was being loaded up into the helicopter. He went to a bradycardic PEA arrest. Around 1540, CPR was started by the paramedics on flight. They did put a binder. They started fluids. They put an IO. They gave him some epi. And they did try to intubate him, but it was really difficult because of the situation they were in, but they were still able to bag him at that time. So during air transport, he was given some blood products. He was given CPR. His end-tidal CO2 was really low, though, and his abdomen was getting progressively more distended. They felt it was secondary to their bagging at that point here. And so now he arrives at 16:13, which is about 40 minutes now, close to 40 minutes. And he's been in the rest now, coming close to 30 minutes now. And so this raises a lot of questions about what we're going to do for this kid in our trauma bay. So let me go through the initial evaluation. I'll ask the question to the group. So primary survey, he was successfully intubated without any issues. However, they noticed he had decreased breath sounds. He had a left chest tube that was placed, but there was no blood, no rush of air. And unfortunately, it was an error in the intubation that it was just too far down. And when they readjusted, they had bilateral breath sounds. So it's probably an unnecessary chest tube for this patient. His circulatory, obviously, he was in PEA at the time. We were continuing CPR. His abdomen was distended. He didn't have any obvious signs of any chest or pelvic trauma, no long bone fractures. And as I mentioned, his GCS was 3T. Now, this kid obviously sounds very sick. Has been down for a really long period of time, and I'd like to know from the audience of, what would you do for this kid? And this raises a lot of questions, even among our group, about what is exactly the right thing to do, not just for this patient, but even for outpatients who have CPR for this long period of time.
Howard, you want to take a stab at it?
I think in the short term, continuing CPR, additional access, and resuscitative efforts would be reasonable. I'm honestly, it's interesting because I would consider all of those, except for Zone 1 Roboa is not an available option.
Don't say the 5-letter word Roboa. Okay.
yeah.
All right, Katie, you have a lot of patients who come in dead.
Yeah. So to summarize, right, it's blunt trauma, has had CPR for like 30 minutes and now is in our trauma bay.
Yeah.
Yeah. So typically our algorithm is continue CPR, bilateral chest tubes and a unit of blood, make sure the airway's okay. That would be our first step.
Yeah, I agree with that. And I would probably, in that, I would also be doing a cardiac ultrasound because I have it in the thing, and I'd be looking in all part and parcel. This to be the NASCAR pit crew, interventions, trying to get a hold of this kid as fast as possible.
Chris Newton, you have some. There's some blunt trauma in Oakland, right?
Yeah, we get some occasionally. So, well, I'm going to state out, the obvious. We're all pediatric surgeons and trained, and so in any normal algorithm, blunt trauma or arrest, you're not going to open the chest and do a thoracotomy. It's been 30 minutes. You should be thinking about when are you going to call this. But he's 10 years old. and that's hard to do. So I think I agree with the crowd. You're going to begin to look at other things like, can I get an ultrasound of the heart? Let me see if there's anything there. You're going to look for anything reversible on one hand, and on the other, you got to get absolute proof that he's really gone.
Yeah.
I think for this kid, given your exam and the history, I think the volume is the most important thing. After you've already ruled out, a pneumothorax on either side, it sounds like he's bleeding his belly and he needs volume. So I absolutely continue. I would give a lot of volume. I'd probably activate an MTP if I thought I had a chance with this kid, to try to get as much blood as fast as I could into him, because you need a pulse back if you're going to go to the OR, which would be the E option. I would not proceed to the OR without a pulse.
I think that, like FAST has gotten this really, bad reputation, but the only true role for FAST is in the unstable patient. I'd say this patient's pretty unstable. You've got a distended abdomen that you're blaming on, bagging, but wow, it'd be nice to have a FAST. Romeo?
Yeah, I agree with all those comments. I do want to say one thing is that, Jessica's comment is very pertinent to us, because like Howard and Chris and I, we've been in the military, and we know that when you get volume up front, you have a fighting chance and stuff. And so this kid, unlike, most of our kids, we weren't giving blood products in the field, and we just happened to have the one helicopter that gives blood products here in San Diego. And so that gave that kid a fighting chance. And then the other thing too is, I think Katie's point as well is like, you bring a crew, paramedics, and the last thing you want to do is tell the crew as soon as they get in the trauma bay, let's stop. I mean, we always go through a role. There's a psychological aspect. They're fighting for that kid. And the last thing you want to do is tell the crews that we're going to do nothing. So I think all of us agree as pediatric surgeons, we want to give a fighting chance until we really prove that kid's not going to make it.
Hey, I'm just curious, of the panelists, how many of you guys regularly use POCUS to assess resuscitation capacity?
Yeah.
So, I mean, also when you do a cardiac ultrasound, looking at that, you're going to see whether the ventricles are flat. That's going to tell you, right. It may not tell you, it's not like, it's not about anatomy and all that other stuff. It's just to tell you, if the ventricles are both plumped up and not moving at all, then you're kind of done. But if they're both flat and they're quivering a lot and trying to find stuff to push around, that tells you that resuscitation efforts are worthwhile. And I think it's a qualitative measure. There's no numbers on that, but I use that with kind of regularity if I find a kid in this situation where there's a lot of unknowns.
So like Jessica said, we gave him volume. He got a fair amount of products, close to 4 units initially, got access. Obviously needed some additional epi, calcium, and bicarb. We did put a left chest tube, and even afterwards, still no blood from the left chest. So everything was pointing to the abdomen at that point here. Did a fast. There was no cardiac tamponade. There was a fair amount of free fluid. And then 1626, we got ROSC. But this kid was way behind the curve. You can see the VBG numbers with the pH of 6.5, and the coags were already were out. And so this kid really needed the MTP. And luckily, we have been working really hard in order to perfect our MTP here at Rady's. So at that point here, like Jessica said, we have a fighting chance. We went to the OR, and our OR start time was soon afterwards once we got additional lines.
Can I pause 1 second?
Yeah,
so,
go ahead.
So first of all, I've never seen a pH, measured that low. Matter of fact, the like our lab basically, I think it gets to like 7, and it's like less than 6.9, and it's done. So it's
I thought the lowest number you get is 6.9.
Yeah.
They read this at 6.5. I'm like, are you sure it's 6.5? Because I've never seen the 6.5 ever. I've seen the 6.9, but never this low. So yeah.
And then the other thing is, I'm kind of shocked at how low his hemoglobin is, even in patients that are bleeding to death. And we actually published a paper that showed that that a hemoglobin less than, I think, a 9.2 was predictive of failure, which I thought was shocking. I was surprised that it was such a high number, but 5.7 is a low number. Do you think they get some secret fluid that we don't know about?
No, I asked about that, that did he get a large amount of, normal saline in the field? And the answer was no, he got probably about 250. But he didn't get like a large amount because that all looks delusional to you. I mean, that's the same thing I thought, but these are the real numbers. Even the platelets, this early on, you don't usually see this numbers this low so early and stuff. So, but the numbers that's what the numbers are. And someone had pointed that out as well about, are these numbers real or are they delusional?
Interesting.
Hey, can I ask real quick, Romeo? So you said you activated MTP, and with those, with those numbers, obviously yes. And I'm going to guess he's roughly, I don't know, 30 kilos. So what is the mechanism of your MTP at 30 kilos? Did you hook up a level 1 or a Belmont, and
We had the Belmont.
do you tag, or you just go as fast as you can with
Yeah, we have tag, but our tag was going to come back in 40 minutes. And then we did give TXA as well. So, yeah. But in looking at the ratios, he really didn't achieve his 1-to-1-to-1 ratios until he was in the OR. At this time here, he was more packed RBC positive than he was platelets, and other products and stuff. So
right at 30 kilos, you're inherently unbalanced.
we are unbalanced. We are truly unbalanced, and we are coagulopathic, which is the issue.
So I'm curious, one thing, Romeo, when you call a trauma MTP at your institution, what actually arrives? What do you get as your first step?
So we get emergency release. That's obviously going to get you the blood faster than the MTP at our institution. And then you get packed RBCs, then you get fresh frozen plasma, and then you get platelets and stuff. And that's new for us. We just got the fresh frozen stuff. So
you guys, and I know this is not common in many places in children at all, but does anybody have liquid plasma already?
We do never frozen plasma. Yeah.
We have thawed.
yeah, thawed.
You guys keep thawed stuff on deck all the time?
No.
Yeah.
Okay. Yeah, we do liquid plasma, and we have and our trauma pack is 2 reds, 2 yellows, and a platelet right off the bat come to the trauma bay.
That's what we get. But
Yeah,
however,
Mhm.
I want to make the argument though is, whole blood would have made this so much easier. Yeah.
We can give whole blood if it's a male over 15 kilos or a female over 15 kilos with a known RH status. We're still working out that last little bugaboo. Below 15 kilos, they don't send us whole blood because it's impractical. The aliquoting and stuff ends up wasting most of the unit. So.
And the audience, who has whole blood?
Have it, although and we use it, but we also waste a lot, and so we're really trying to we're making our cardiac people suck it up. So
yeah, we're incorporating it into ECMO primes and spinal cases as well.
Yeah, you gotta find somebody to use it if you're gonna have it.
And there's also in Texas, there are several communities that have a whole blood pre-hospital to hospital and then to componentalization plan where they cycle it back so they limit their waste as much as possible, but we've not enrolled in that yet.
Nice.
David,
all right.
You want me to just go through the case, or what do we want to do at this point here?
Yeah, I think so.
I just want to be respectful to Jessica's time as well.
Yeah, let's do it.
Right. So we did a standard trauma prep and laparotomy, gave additional blood products, but really concentrating on giving more of the FFP and platelets. And we finally got our tag, and we were way behind the tag. I don't have the numbers here. Sorry about that. We quickly saw the blood was coming from, the right upper quadrant, left upper quadrant. Immediately, we had lost a large amount of blood upon opening the abdomen, and basically, we did what we call it in the military a RAHOA, a retrograde hand occlusion of the aorta. That gave time for the anesthesia to catch up. And so I know Chris and Howard know this, but we are literally trying to get the anesthesia to catch up. You put your hand down there, and when I put my hand down, the first thing I noticed is I never felt liver. And so clearly we were at probably a grade 5. I didn't feel anything at all on the epigastric and stuff. And we'll show you some pictures here in a few slides. There was no evidence of any splenic or pancreatic injury. Again, this is after we've taken out all the blood and stabilized things. We packed with quick clot and we did the sandwich above and below, and there was no evidence of any pelvic hematoma. This is a very oversimplification of what we did, but again, I talked to residents about how we packed the liver. It's really important, and you really want to do that sandwich there to get, adequate hemostasis. We know there was a deep liver laceration all the way anteriorly down to the IBC through segment 4, and there was a large amount of bleeding vessels that we were ligating and also packing at the same time. Patient at this point here was stable, and anesthesia did an amazing job in keeping up with the blood loss that we had. We did do a Pringle maneuver on top of the other things I've mentioned. And at that point here, I was communicating with the anesthesiologist of where we are with our numbers. I did also know at that time is that the edges of the skin were starting to ooze a little bit, and the kid's body temperature was quite cold. And so if you look at the numbers here, temperature was 33. The hemoglobin was now up to 9.5. We're still acidotic. And I feel that we need to get out of the OR at that point here because we were now losing the battle with coagulopathy, and we just need to give the kid more products in order to stabilize the numbers here. I'm gonna go quicker, David. That's okay with you. So
You're fine. We're trying to get through 3 cases, so we're okay.
Okay. So next step. So here's a kid who's coagulopathic. You got this liver packed. You've taken care of some of the bleeding vessels. There's still some oozing. It's all, a grade 5 liver. What would you do at this point here? Would you transport the IR to attempt mobilization, go to the ICU, warm and optimize coagulopathy, or complete the liver resection so you can get better control and better visualization where the bleeding is?
All right, Dr. Naiditch.
It's either A or B. I think it really just depends on after you've packed the abdomen, do you feel like you got any sort of control with your temporary closure? And how available is IR? Can they get there that fast? The college requires them to be there in 60 minutes, but we know, from doing reviews that that's pretty hard for pediatric centers to do sometimes. So whether you're going to the ICU to warm up and work on your coagulopathy while you're waiting for IR or going straight to IR, I think it's one of those two.
So interestingly, we just hired our IR guy. I just completed the algorithm and the protocol for our IR. We've never had a trauma IR case until today.
Wow.
So.
Before we move on too much, we use the term packing the liver, and it's so ingrained in trauma that we'll never get rid of the term packing the liver. But I think when we teach the trainees, I like to kind of think of it as we restore the liver, we reform the liver into the shape of the liver. And because if not, they think that they're supposed to be putting packs in between the cracks, which is the last thing that you want to do. And for those of you who haven't done one of these, don't pack in the liver. Okay, yeah. Pack around the liver.
Yeah, and that's a good point and stuff, because that's exactly what we did in order to sort of get a little bit more hemostasis on this liver. But Jessica, what I did was this kid was sort of losing the battle from a coagulopathy, was cold. This is sort of that triad of death, and we needed to get to the ICU and warm up the patient and get our numbers a little bit better.
Yeah, I agree with that.
So
yeah, that's a good call.
Yeah. So once we did that and the numbers were improved, and it took us probably only a few hours for the TEG numbers to get better, we did go to IR, and you can see obviously the study here. The study looks good here, but what you don't see, I'm sorry the video doesn't work, but there is some extravasation that you could see on the left and the middle areas here. And again, the videos doesn't work too well.
Are you sure? Because it worked for me. Okay. All right.
Oh, did it work well?
Yeah.
Try.
Yeah. Caitlin, if you can press the play button.
You see.
Right. Just hover over the image.
Okay.
Maybe not. All right. You're right. Okay.
Yeah, I didn't have it for me, so. We did a left hepatic artery embolization, and I wish, again, it would be great if I could show this video and stuff. And then you can obviously see our packings to the side, packings to the left, and what you do see is there was still some extravasation toward that middle area, and we end up doing an embolization along near that segment 4. Yeah, sorry, the video's not working.
Hey, and I know you want to move through this quickly. So I think it's really important that we talk about the decision of how long when you've been in the ICU long enough. And I think that because this is something that you really have to have in your mind, because a lot of times it's like 2 or 3 in the morning and it's harder to think. But like, what is your trigger for, I've been in the ICU long enough, we need to go to IR? How do you make that decision, Romeo?
So once I was in the ICU, when I felt our coagulation numbers, our TAG was doing much better, our platelet numbers were much improved, and we were no longer requiring increasing requirement for blood products or pressures. I think that was the sign where the kid's physiologically heading toward that right direction. I don't think you'll ever get those numbers perfect, but at least we're heading toward perfect. And so my coagulation was my #1 priority for this kid. #2, hemodynamics and the additional need for, ICU care for, hemostability. And this kid, surprisingly in 6 hours, and I think most of that was because of the anesthesiologist who did a great job in the OR of keeping up. So that's why I would prioritize those things of when to leave the ICU. You can get lulled in staying in there for, 2-3 days, and next thing you know, the kid's all like the Michelin man, all swollen, and you haven't done yourself any favors at that point here. You're just giving too much of blood products and stuff, and you'll never get those numbers perfect, but you'll get them close.
Yeah, you nailed it. That is just so important. You stay in the ICU until you are happy that you are clotting, and then it's surgical bleeding, and now you have to handle it. So nice.
So if you look at the numbers here, again, but this is now probably close to 18 hours into this. Our numbers are not perfect. And so we've given a lot of packed RBCs, and given some FFP. Our platelets, we're only given 3. So again, we weren't perfect and stuff, but our TAG numbers were now driving us of what to do. And so we weren't trying to, as much as we talk about 1-to-1-to-1, once you get to 1-to-1, we let our TAG numbers and the patient's clinical status of oozing decide where we're going to go for the meantime. And at that point here, our temporary closure was not oozing as much. The bowel looked pretty good, and the TAG numbers were improving.
Fantastic.
Unfortunately, I'm going to disclose one of our M&Ms here and stuff, is that we end up having that chest tube started oozing, and we did have an intercostal bleed that we had to address. And unfortunately, I couldn't address it through a small incision, so I had to make the chest tube size a little bit bigger, evacuate the hematoma, and take care of that. The kid's temperature improved over the next 24 hours. The requirement for epi increased and then decreased, and now our gas is in 24 hours. I mean, it's pretty good. Our coags were not better, but like I said, they're not perfect, but they're heading to a better direction.
When you say from the abdominal closure, there was ongoing bleeding. How did you guys address the abdomen, the abdominal wall?
So the abdominal wall is, I put this Apthera on initially. And of course, this is not one thing I use regularly. I don't know if any of you guys use it. And then I realized how much I don't like it anymore. I'm never going to use it again. and then I used the old-fashioned blue top closure, which worked perfectly. And it stuck better and was adherent better. So I'm sorry for if any of you guys like the Apthera, but boy, I quickly learned, like, you're always trying to learn new tricks of the trade. And you have a smart fellow who says, yeah, Apthera works. And then I looked at it and quickly learned in 12 hours I'm never going to use that again. So yeah.
Nice.
All right.
All right.
We're ready to pass this part here. So we return to the OR. Again, this is operation number 3 now. And I want to show that this kid is looking much better. They did give some Kcentra, something I don't usually typically give. They felt that would be less volume in comparison that they were give, and they really wanted to try to improve it. My concern now is this kid was down for 30 minutes and we were going to go to the OR. What was the kid's, head status? Did he suffer a hypoxic injury? Did he really was going to be one of these kids that would not have a non-survivable, injury to his head? And so we got an MRI, which really just showed a very, very small area of hypoxic injury, but globally it looked great. He still had good perfusion, no signs of edema, no signs of any hyperperfusion to the head. Go through these real quick. I'm sorry, I'm already past this part here, sorry. So we went back to the OR on number 2. We took a look at some of the bleeding. That bleeding that the IR took was much better. The left liver was ischemic and minimally oozing. The right liver had good perfusion. And at that point here, the question is, what would you do about that left lobe of the liver? Would you leave it? Would you keep it in place and stuff? And this is the part I would love to hear some comments about, because we did have some discussion about what to do about that left lobe of the liver.
All right, Katie, blue liver after embolization.
You did not embolize the left hepatic. You embolized something distal, right?
Yeah, distal.
I mean, you see it. I would try to leave it.
Yeah.
Yeah, it's hard to say without like actually seeing it, but I think I would try to leave it.
Yeah. Anyone else?
Howard?
I would definitely leave it too. I mean, particularly it's been packed. There's been an embolization. I would just give it a chance to figure itself out. Depending on how it looked, I may not be that excited about closing the abdomen on this particular trip to the operating room either, and might come back and look at it unpacked another time in 24 hours.
And that's why I left it. It's there's always this dilemma of trying to, we always leave the liver, but many of us have known is that sometimes you get that liquefaction necrosis, the fevers, and then you're chasing your tail. I decided to do exactly what, Howard and Katie said, just leave it and see what it looked like on the follow-up visit.
I don't know. I'm not a big fan of leaving dead liver, but okay.
Oh, but you're not wrong, David.
What would you do? Just take a wedge, Notrica, like right there?
Well, usually it demarcates, and you can basically just take the stuff that's black.
But would you do it at that moment, or would you come back when it's more declared?
Ooh, I don't know. What time is is it 2 in the morning, or is it?
These are the take back, yeah? These are hopefully during the day.
Romeo,
No.
we want a picture.
Yeah. Okay. I'll get past this part. I'll show you a picture, but actually I won't show. It doesn't show well, but I'll show you what I end up doing with that liver. But David's not. There's some wisdom there what he just said. So, like I told you, I did a mini thoracotomy. I evacuated a hemothorax from this chest tube complication that we had, and then put some pericostal sutures to stop the intercostal bleed. I'm gonna pass this part here. So that's the liver there, and it looks pretty good to you, but it was pale and it was dark looking. And so at that point here on operation number 3, I just took out that portion of that liver that really wasn't doing. And there was, you don't see it here, but there's some liquefaction necrosis on there, and there was no evidence of any flow anymore to that liver. So I did what you did, David. I first waited and declared itself, and then after the 3rd operation, I said, this is not going to survive. I brought one of my partners who does a lot more biliary stuff, and she said the same thing. She said, yeah, this is not going to survive. And so it was great to have Karen Kling help me to do this operation. And we ended up taking out the liver. Any comments, David, about it?
No, I think it's great. I don't think the timing of it is like super critical. I think what happens over time, because my experience is when I've tried to leave dead liver in, they have fevers, they have pain, they open their wound, it just doesn't end well. You do it when you think you can do it.
Yeah, that's exactly why I hate the fact that we live this dead liver and we chase our tails. It ends up being this big fluid collection. We put drains. You end up having this bilo. I mean, it's just nonstop. And so I'm glad I ended up doing this. Okay.
Oh, cool.
Ooh.
And that's a good case. That's fun.
So stomach here, liver here. Obviously, it's viable here. This is the part of that liver that was re-resected. It's actually a very small area, about 3 by 2 centimeters. It was hanging on, so it was very easy to do. and the rest of it was finger fractured and ligated. So it went fairly straightforward, but I did decide to leave it, and I hemmed and hawed about doing the second operation, but I'm glad I sort of waited.
How did you take the liver down?
What do you mean? Just what?
Stapler, ligature, with like hand tie specific
tie.
muscles? Hand tie.
Yeah, finger fracture, vessel ligation, you know,
Old school. Love that.
old school, yeah.
Yeah. Ooh, nice pictures.
Not as nice as the glass one, though. So this kid went multiple operations and did have some bile that was leaking from one of the drains I left. The ERCP was done to put a stent in order to preferentially get the bile go to the GI tract. The drain did stay for a while. The kid required multiple operations to gradually close the abdomen. Did end up having a fungal bacterial peritonitis that was treated with antifungals and bacterial. Sounds like a long course and stuff, but the great part is on day 31, this is him.
Wow.
No neurologic injury.
Wow.
Well, didn't even have to go to rehab. And the great part of this story is this kid is like one of those trauma survivors that does all the American Red Cross stuff for helping us get people to transfuse blood. And he also helps us with CPR courses and stop the bleed. An amazing kid. And so I wish I had the video to show when he was walking down the hallway, but this was a great save for us. So
Yeah.
It's incredible.
incredible.
That's great CPR.
Yeah.
Yeah.
High quality CPR for real.
yeah.
It turns out no matter, how much literature you read or how much, you think a patient's non-survivable, our ability to predict who's alive and who's dead is just not that great. All right, I'm gonna that's a great case, but I want to quickly get Dr. Naiditch in, who also has an amazing case, and we'll rock and roll through that.
I'm gonna get this. All right. So y'all see my slides okay?
It's beautiful.
All right. So we're taking call at your level 1 trauma center. 8-year-old boy comes in after an MVC, front impact, restrained, back seat. And EMS notes that he has decreased movement to his left lower extremity specifically. When he gets to your trauma bay, he's got an intact airway. They put a cervical collar in the field. Good job. Breath sounds are equal. Vital signs are not that remarkable. It is noted that the lower extremity pulses are diminished, 1+ femorals. I couldn't find distal pulses, DPs or PTs. They got some IV access, and the abdomen was soft, and I'll show you a picture of his belly in a second. GCS was 15, and they confirmed decreased movement and sensation to the left lower extremity. And when they got him undressed, they saw it a lower abdominal seatbelt sign. Not markedly distended, maybe a little bit, and only mildly tender. So just given that story, what are you concerned about?
Dr. Newton.
I'm worried about bowel and spine and vascular injury, kind of all at once.
Dr. Russell?
Totally agree.
Yeah, statistically, if you have marks on your abdomen, there's a very high risk that you have an intra-abdominal injury. So, all right, I think you nailed it.
So since we don't have much time, this was a trick question. Next move, because we haven't finished our primary and secondary survey in this stable patient. So it was noted that the lower extremities were cool to the touch. I had mild abdominal tenderness. Rectal exam was remarkable for what was described as no tone, and he did have a step off and a hematoma to his lumbar spine. His cervical and thoracic spine were without tenderness. He did get chest x-ray, pelvic x-ray, which were normal. Labs were kind of unremarkable. And I'm going to assume everyone will go to CT from here in the stable patient with all those findings. So we went to CT, we got CT head that was normal, and then CT chest, abdomen, pelvis, so that we could see the entire spine specifically. And this is some shots from the CT scan. And I want you to focus on the aorta here. As you follow it down, you can see actually no splenic or liver injuries, no renal injuries. But eventually, you can see a lot of fluid around that aorta, and then the aorta disappears,
Wow.
and does not reconstitute lower down. So that was our imaging there. There was also a little trace-free fluid in the pelvis, and a chance fracture, L2 chance fracture noted on the lumbar recons.
Was there a flow in the iliacs, or there was no flow you saw there?
No flow to the iliacs, and they could feel femoral pulses, like 1+, but nothing distal on exam.
Romeo?
This is gonna be a tough one here. And the patient's stable right now?
Yeah.
Yeah. So similar to Howard, I try to get some endovascular consultation if it's really available to our hospitalists. Keeping in mind that this kid can turn the corner fairly quickly, and being prepared to go to the OR to obviously get proximal and distal control. The issue is that, you know, doing these vascular operations, these kids and stuff, we do it because we have to, but we don't do it very often. I do think if there is an option for an endovascular with a, you know, a hybrid option, that would be fair. But you have time; they're stable. But again, I wouldn't try to give a large amount of fluids because you'll just exacerbate the bleeding. I would have all the blood products and stuff ready to go just in case this kid turns the corner.
Howard?
Yeah, I would be all of that. I would get prepared for a major exploration, although I would not be excited about doing that. And I would be interested in trying to do as much endovascularly as humanly possible before I got into all of that excitement.
So we call our vascular surgeons.
Yeah,
We do
I think this is old school vascular surgery. You know, I think this is a transected aorta with no flow to bilateral lower extremities, and this kid needs to be in the OR with an X-lap, and whoever is the best person that can help take care of that situation.
How old
Actually, this is
a kid who's stable. I agree. We're not gonna wait 6 hours crazy like that.
I think though that thing can blow at any time. Like you want to keep the blood pressure low. Like that aorta, the adventitia is like holding that thing in place. Like it is like a ticking time bomb.
I'll be interested to hear what the findings are, but this actually might be bruised adventitia and a traction injury where where it tore the endothelium, and is actually just blocking it off because it's too blind-ended for that to be a completely transected aorta.
And you have palpable femorals, and so
1+, described as 1+.
So this is a traction intimal
some
tear.
flow.
I'm not saying, Katie, that you wouldn't do the old school, but I do think you look at other options first. And if you have no other options, then it's all old school. But yeah, it's a ticking time bomb, but you have time at, you know, and just depends on what the kid's gonna do.
I'm not as convinced that you guys that, and so when I have a dissection, yeah, I love endovascular. The last popliteal I did ended like this, and the popliteal was in 2 pieces.
Yeah.
It was in 2 halves, just wasn't connected.
So we have vascular surgeons who do all the things. So we called them, we said, help, come look at this, look at the scan. They felt an open approach was necessary based on the size of the kid and the imaging findings. And then their next thought was, what the heck are we gonna use, right? Because this is a little kid. You can't put like a, artificial graft in there. It's not gonna grow with the kid. So they had to search around town to find the right size cadaveric vessel to use. So we did go for an X-lap, Katie, happy to report. Found about, initially started by our general surgeon, found 70 centimeters of devascularized small bowel that was resected, some colonic hematomas they didn't touch. And then vascular surgery got there and found essentially what Dr. Pryor described, an endothelial injury with the adventitia still intact. So they heparinized, got proximal distal control, and then reconstructed the aorta and the bifurcation. I'll show you pictures in a video in a second. As they were closing, they took the retractors out, and there was a very long segment of small bowel with a hematoma, probably from those retractors and the heparinization. They didn't touch it, they left it there. And yes, the kid got a bowel anastomosis at the same trip. So this is what they found once they did their Cattell Brash and was able to expose the aorta. This was after their reconstruction of that bifurcation in the distal aorta with cadaveric graft. And then this is a little video.
So
Wow.
what size graft did they use for the cadaveric?
Ooh, I'd have to look.
Yeah.
I don't know off the top of my head.
Okay.
But they did base it. They found a small adult graft that they used for this.
Okay.
Mm.
Hmm.
Pretty
What's
cool.
shocking though is the size of the graft that it took in order to fix it, and that is really common. Is you've got you take out this much, and then you have to, replace that much.
Did they ever circle back and discuss other options that they could have considered?
They considered endovascular. They did. They didn't think it was a good option for this kid with just the size of stent grafts and how you're going to overlap them, and it's at the bifurcation and all that kind of stuff.
Yeah, Howard, I think the
So
bifurcation.
they thought this was the best answer for this size patient.
Yeah.
Yeah,
Yeah,
they-
that might be.
Yeah, they would have to overlay the stents, and those stents don't necessarily grow with the kid, and that long term won't be so great. I didn't realize how proximal it is to the bifurcation.
Yeah.
Great
Yeah, I
case.
mean, and then the kid had bad bowel and other injuries in the abdomen, so it's
Had to go in either way. Yeah.
It's interesting that we have a kid similar to this higher up though, where they put a stent graft in, not at the bifurcation, at the descending thoracic aorta that gets dilated. The graft gets dilated as he grows every once in a while, and he's otherwise doing great. So it's just kind of interesting to see the different approaches. It's definitely not my.
Well, and then you got to think about all the CTAs that kid's going to get for the rest of his life, right? This kid, no stent graft. You have to look for endoleaks and things like that. So also had that chance fracture, got an MRI, no pressure on the spinal cord, although there was a long, thin epidural hematoma. Since we're out of time, I will rush through this last part. He did very well, actually, got extubated, tried to wean his NG tube to gravity, but then had large bilious output, and then got a CT post-op day 5 that showed a very nice flow through the aorta, dilated small bowel. You can see a wide open anastomosis, but there was that small bowel hematoma was causing obstruction. So we watched that. We did not operate on that. We gave it more time. Eventually, his small bowel obstruction resolved. He then, after that, went for his prone posterior spinal fusion with orthopedic surgery, and he's had a full neurologic recovery in his lower extremities on aspirin.
That's awesome.
Yeah, it was a good case. Very, very grateful for the vascular surgeons that help cover us. I know some centers have trouble finding that, but they did a great job and responded quickly. Because I don't do aortic reconstructions. I don't know about you guys.
That's an incredible case, and super enlightening too. And the discussion about when you stent and when you repair, certainly not it's not an easy decision. And you look at the aortic bifurcation there, and one of the cases that we had recently, they were fine to repair one side, but they had to plug the iliac into the other iliac. So it was they're challenging cases. And then you think, oh well, this is a short segment and I can replace it with a short segment, and it just doesn't work that way in the aorta or the iliacs, as you saw. I'm not sure how much they excised, but I assume they didn't excise anywhere near that much.
Yeah,
It's a great case.
Yeah. Cool. Awesome.
What follow-up studies have been done on the aorta? Do you know?
They did an ultrasound before he left the hospital, just to get an ultrasound baseline of what it looked like so that we could avoid the repeat CTs, and then had follow-up with them, and is following with them like annually with that on aspirin.
Some form of imaging to just check on it.
Nice.
Katie, you called it.
Yeah.
Well,
Easy
I mean, I
call it.
think this is classic pediatric surgery case, like the thin kids that have that low seatbelt sign. I think I've just seen it, like we've had like 3 of them. And that's just how we've treated them. But I think we're probably less advanced on the endovascular front as well. We tend to go old school.
Yeah.
I just sent one home yesterday with the seatbelt sign and a mesenteric injury. And I was like, I was looking for and a chance factor, and I'm looking for the aortic injury, and luckily they didn't
Right.
have it.
Yeah.
I mean,
Our-
Newton called it. He said the bowel's going to be bad, the aorta's going to be bad, and the spine's going to be bad. It's like
Right.
the very first thing we said.
All three.
Man,
It's good
That's
case.
fun.
it's a great
That's
case.
Good saves,
Good
guys.
work.
All right. Well, we are at time, and I really appreciate it. A couple of comments. Romeo said, humbled by the young Katie Russell telling the older Nate surgeons to go old school. I love that comment. All right, look, this is super fun. Dr. Russell didn't get to do a case, but she did one last year and the year before. So we felt if someone had to not make it, it was going to be her this year. Really look forward to doing this. Look forward to seeing you guys next year. Usually we do this in October, and you know, that's awesome. We'll let everybody go. Thanks.
Thanks,
for having
Notrica.
us.
Everybody.
That's really fun. Bye,
Yeah.
guys.
Thanks, guys.